Thank you for joining us. My name is Audrey Hassan, patient liaison for the MDS Foundation, and I'll be moderating the presentation today. As we get started, I would like to thank Acceleron, Bristol Myers Squibb, Jazz, Novartis, and Takeda for supporting this webinar program. Please note that this is a pre-recorded presentation, so the presenter will not be taking any questions. The live questions with answers opportunities for all participants are included at the end of this presentation. Today's presenter is Dr. Casey O'Connell, a hematologist at Keck Medicine and an associate professor of clinical medicine in the Division of Hematology at the Keck School of Medicine at the University of Southern California. Dr. O'Connell specializes in myelodysplastic syndromes and myeloproliferative neoplasms, and in addition to teaching and seeing patients, she runs clinical trials that aim to identify new therapies for patients with these cancers of the bone marrow. She is committed to research that reveals how we might intervene earlier and more effectively to stem the development and progression of myeloid cancers. So with that said, it is my pleasure to introduce Dr. O'Connell.
Good afternoon, everyone. My name is Casey O'Connell. I'm a hematologist at the University of Southern California, and today I'd like to speak with you about low-risk myelodysplastic syndrome. Can we stop it? So the objectives of our lecture today are that you should be able to explain how the basic function of the bone marrow is altered in myelodysplastic syndrome. Number 2, define clonal hematopoiesis of indeterminate potential, a relatively new term that we call CHIP. Number 3, distinguish CHIP and low-risk MDS from higher-risk MDS. And finally, and most importantly, you should be able to discuss some therapeutic options for low-risk myelodysplastic syndrome. Let's start with a question. How does a factory making 310 billion cells a day, every day, for 80 plus years continue to function so well? Well, the blood factory consists of 3 major components. The stem cell, which gives rise to every blood cell, the ingredients that we need, like the building blocks of those stem cells, and then stimuli from our body that tell the bone marrow to make more or less of a given cell type. So when we talk about ingredients, those are proteins, iron for red cells, oxygen, B12 for all of the different blood cells, folic acid, copper, and others. Most of them come from our diet. We need the stimuli, which are cytokines or hormones that the body secretes. Erythropoietin is the hormone that comes from the kidneys that tells the bone marrow when it's time to make more red blood cells. GCSF is the hormone that comes from the blood vessel linings and from immune cells when we need to make more neutrophils, or a subtype of white blood cells. And then thrombopoietin is the hormone that comes mainly from the liver, which stimulates production of our platelets, cells that we need to help stop bleeding. And then, of course, we need that source to be waiting for the signal to get stimulated and then to proliferate. So what is that source cell or stem cell? Scientists define a stem cell as a cell that has 2 major properties. Number 1, it can replicate itself. And number 2, it can differentiate or become more mature, and that differentiation can go down many different pathways. So the stem cell has the ability to become many different cells depending on the signal that the body's giving it. So how can this amazing factory go wrong? Well, the normal stem cell is there waiting for its signal, but if aberrant signals or aberrant what we call epigenetic programs ensue, then that stem cell may become somewhat abnormal, and in myelodysplastic stem cells, we have cells that have picked up a mutation that then may give us blood cells in an unusual fashion or in a reduced fashion. If those MDS stem cells pick up additional mutations or aberrant signaling signals, we can end up with acute myeloid leukemia. So MDS is a pre-leukemic condition, meaning there is the potential to develop into acute myeloid leukemia, a more aggressive bone marrow cancer. So what is MDS? The word myelodysplastic syndrome comes from Greek words. Myelo means marrow, and yes, MDS arises in the bone marrow. And then dysplasia means abnormal growth. So these stem cells giving rise to new blood cells are doing it in an abnormal, ineffective fashion. This is an example of a neutrophil, one of our white blood cells that fights bacterial infections, which in this particular picture looks a little unusual. It only has 2 lobes in its nucleus instead of the usual 3 or 4, and it doesn't have lots of infection-fighting granules in its cytoplasm. So dysplasia is easiest to see when we look under the microscope at the peripheral blood in those neutrophils. Here's a picture of normal neutrophils with multiple nuclear lobes and lots of little dots in the cytoplasm, which represent those infection-fighting granules. Here are real live dysplastic neutrophils where there's one big nuclear lobe and not the normal dark dots in the cytoplasm. So myelodysplastic syndrome is typically defined by 1 or more low blood cell counts. And anemia is shown as the largest circle here because it is the most common problem that we encounter with myelodysplastic syndrome. And when we meet a patient with anemia, our number 1 job is to first make sure that there isn't a reversible cause. So I've listed a few here. For example, if a patient is B12 deficient, we may be able to correct the anemia by giving B12. If there's liver disease or an enlarged spleen, or the patient is bleeding, these are all correctable causes for anemia. So we generally start there. But if we can't find a reversible cause, then we consider going to the bone marrow. Ultimately, patients with myelodysplastic syndrome can have more than just anemia. They can have low platelets, otherwise known as thrombocytopenia, or low white blood cells, otherwise known as leukopenia. And they can have any combination of these 3 low counts. As I mentioned before, this is a clonal disorder. Clonal means that the abnormal cells are coming from one mutated earlier progenitor cell. And unfortunately, it is a disease that can evolve toward acute myeloid leukemia, a more aggressive cancer of the bone marrow. We'll talk about now that MDS is no longer really one disease. It's very heterogeneous, and different patients may have very different manifestations. For example, here are some subtypes of MDS that now sort of have their own category. The first here, CMML, chronic myelomonocytic leukemia. This is a disease where there are too many of a certain type of white cell called monocytes, but there's still dysplasia and there's usually still other low blood cell types. In addition, it too can evolve to acute myeloid leukemia. CMML is often grouped together with MDS when we do clinical treatment trials in higher risk diseases. The next one is MDS with deletion of 5q. 5q refers to one of our many chromosomes, which in this particular case, a piece of it is out. And in this particular disease, which is very low risk, it can be treated effectively with a drug called Lenalidomide. The next group is sideroblastic anemia, and in particular we are seeing a recurrent mutation of SF3B1 in patients with this form of anemia. We have a newly approved drug to treat these patients, which I'll talk about in a bit. We've pulled out patients who have myelodysplasia but high blood cell counts into an MDS-MPN overlap syndrome. And CMML is an MDS-MPN overlap in terms of how it presents. But there are other patients who don't have CMML, who maybe just have too many neutrophils, and whom we will make this diagnosis as opposed to simply MDS. And lastly, and very importantly for this talk, we have a group of very, very early MDS patients that we are now calling CHIP or CICUS or ICUS, and I'll tell you a little bit more about what those mean in a moment. These patients might be thought of as having a pre-malignant clone of stem cells that has the potential to evolve into a more overt MDS. No need for us to walk through every one of these, but if you see going from left to right, as time has gone on from the 80s to the early 2000s to more recently, we have become a little more refined in our subtyping of MDS, and that is having more relevance both biologically in terms of how the patients behave, but now also with treatment options. So most patients want to know what causes this. Why did I get this in the first place? We know that MDS represents acquired DNA damage. So even though the damage and the abnormality has occurred at the level of the gene, these are generally not mutations that are inherited in families. These are mutations that get acquired, usually sometimes in adult life. And why might that happen? Why might the DNA in our bone marrow acquire a mutation? We are seeing this quite a bit with chemotherapy. So unfortunately, although people are living much longer now after having had chemotherapy for cancer, one of the things that can ensue down the line is MDS. Exposure to benzene or other chemicals that people may have had in the workplace, exposure to radiation, which could be workplace related or could be for treatment of cancer. Another area of intense interest is whether MDS arises as a result of immune dysregulation, which we know is one of the characteristic features of aging. And MDS is generally not a disease that occurs in children and increases with age. So immune dysregulation may play a role in allowing the abnormal stem cell clone to begin to grow. In the majority of patients, we call the MDS idiopathic, meaning we don't know why it develops, but we will continue to study this area. One of the interesting things about these mutations that we're finding in the bone marrows of patients with myelodysplastic syndrome is that the same mutation may cause a slightly different disease in a different patient. And we don't entirely understand why that occurs, whether that's due to certain combinations of mutations causing blood cells to behave in a certain way, or whether features of the patient themselves, the host, are modifying the way the mutation's affecting their blood. So here I show AML at the top, MDS at the bottom, and then those myeloproliferative neoplasms, or MPNs, that I mentioned, where the blood cell, a white blood cell, for example, may be very high rather than very low. And then in MDS-MPN, there's a crossover where there are some low cells and some high cells. But as you can see, these circles overlap because there are shared mutations between these different diseases. So once scientists discovered that there were so many mutations that we could find with very astute molecular analyses, they applied those analyses to patients of varying ages without any known blood conditions. And here you see that in a couple of different studies, they have looked at patients going all the way down into their 20s, where you essentially see no one with a mutation. And after about age 40, we start to see a very slight increase with age in the number of normal people with normal blood work that carry these mutations. And if we get up over 80, that number is as high as 15 to 20%. So this is something that is relatively new, and so we have created a term for this called clonal, meaning there's a mutation, hematopoiesis, meaning the mutations occurring in the cell that gives rise to the blood cells, of indeterminate potential, meaning these people don't have an overt cancer or MDS yet, and so we're referring to this phenomenon as CHIP, clonal hematopoiesis of indeterminate potential. What has been identified, and I'll tell you a little bit more about it later, in patients with CHIP is that they do have an increased risk of developing a blood cancer over time. And currently, the estimate is approximately 1% risk per year of developing an actual overt blood cancer, such as MDS. Going back to the epidemiology in general of MDS, not specifically CHIP, but CHIP follows the same pattern, we see that men have a higher incidence than women of clonal hematopoiesis and myelodysplastic syndrome, and that rises substantially as they get above the age of 70. This is showing over the decades since we've had SEER data. Are we seeing an explosion of MDS? Not really. We've seen a slight peak in the diagnosis here around 2010. Now that we have these very fine molecular studies, we may see that number begin to go up again. So we understand that there are mutations, that patients develop low blood cell counts. How do you know where you fit in the overall scheme of your risk of developing acute myeloid leukemia or your risk of having a more progressive, severe disease? The arrow here is pointing to the group of patients that we're going to discuss today, which are patients considered very low risk. That's the solid bar. And the picture on the left shows you the overall survival of those patients, which is the best in this group. It is the worst in patients with a high risk or very high risk disease. Similarly, the risk of evolving into acute myeloid leukemia is actually quite low, less than 20% of the patients with very low risk MDS. So their complications and concerns may be different from patients with very high risk MDS. The high risk patients generally have some grouping such as blasts, which are the leukemia cells in the bone marrow, greater than 10%, more than 3 cytogenetic abnormalities, and an abnormality in chromosome 7 or 3 is usually considered particularly high risk. Whereas low risk patients may include patients with the isolated 5q-, that deletion in 5q that we talked about, fewer than 2 to 5% leukemia cells or blasts in the marrow, and often a single cytopenia. So as we think about treating myelodysplastic syndrome, and specifically low-risk myelodysplastic syndrome, first we need to address what are we trying to achieve. So generally speaking, patients are coming to us in the first place because they have a low blood cell count or a cytopenia. So if that cytopenia becomes significant enough that they're feeling very tired, for example, because of anemia, or they're getting infections because of low white blood cells or leukopenia, or they're starting to have bleeding manifestations from thrombocytopenia or low platelets, then our first goal becomes how can we improve the cytopenia? And what I list here are things like decreasing the transfusion need, which can be very burdensome to patients, improving symptoms, and then reducing the risks of bleeding infection. And I'll talk a little bit more about cardiovascular events. Number 2 is we want to decrease the risk of transforming to acute myeloid leukemia. As you know, this is a more aggressive cancer that requires more aggressive therapy. And in doing so, we generally want to reduce the number of blasts. So the definition of acute myeloid leukemia is greater than 20% blasts in the blood or in the bone marrow for that patient. So an MDS patient may have up to 20% blasts before being considered in transformation to acute myeloid leukemia. So we'd like to reduce the number of those leukemia cells, and we'd also like to reduce the time it takes for a patient's disease to evolve toward transforming to AML. And lastly, but probably most importantly, is we want to extend life. Of course, we want to do it with the optimal quality, but the term that we use in clinical trials in this regard is the median overall survival. And so we're often trying to push that median overall survival further and further into the future. Just a couple of terms that we'll use when we talk about treatment responses. Number one is complete remission, or CR. It's very difficult to achieve a complete remission in myelodysplastic syndrome. It requires us to have almost normalized the CBC, or complete blood count, meaning the whites, the platelets, and the red cells are all back to normal. We want to see that the bone marrow actually looks normal again. If the cytogenetics were abnormal, they now need to have gone back to normal. And even if we do achieve a complete remission, it's important to realize that this is not the same as achieving a cure. Our medications may get us a complete remission, but they almost never get us a cure. Allogeneic stem cell transplant is still the only modality that we may mention the possibility of cure with. ORR is overall response rate, and this refers to including any of the following: an improvement in the red cell number, platelet number, or neutrophil number, becoming transfusion independent, having a significant reduction in the number of blasts in the bone marrow, but not meeting that definition of complete remission. So just to be clear, overall response rate would include complete remission and all of those responses that don't meet complete remission definition, but are still considered responses. So this is a nice algorithm for how we approach the treatment of low-risk MDS. So patients who are low or intermediate risk MDS and have symptomatic anemia, which is again the most common but not the only group, for those, we first want to define whether they carry that deletion of chromosome 5q that I mentioned, because those patients who do carry that chromosome may respond to lenalidomide, a very specific therapy that works very well for them. What we do as well is to use something called the erythropoietin level that the patient has. So patients who are not making erythropoietin, that's that hormone that stimulates the bone marrow to make those red cells, will actually benefit from being given erythropoietin, and that can be done before they need the lenalidomide. And then among patients who don't carry that 5q deletion, we would do the same thing. If they have a lower serum erythropoietin level, we would give them erythropoietin, and we may also be able to combine that with another stimulating agent. But if it's above 500, meaning their body's already telling their bone marrow, come on, we need more red cells, then we might think about some newer agents, which we'll talk about shortly. There's also a potential role for immunosuppressive therapy in this group of patients. So let's first talk about those stimulants. So erythropoietin stimulating agents, you may hear them called ESAs. They work the absolute best if the patient's own erythropoietin level is less than 200, but we use them all the way up to a level of 500. Examples of these medications are Procrit, Epogen, or Aranesp, and they can be used once weekly or once every couple of weeks in some cases. We usually start with the erythropoietin stimulating agent and follow with a neutrophil stimulating agent if the erythropoietin stimulating agent starts to lose its efficacy. So neutrophil stimulating agents such as GCSF might be called Neupogen or Neulasta. GM-CSF, which stimulates granulocytes and macrophages, is called leukine. And these actually synergize with the ESA to improve the hemoglobin. They are included in the National Cancer Center Network guidelines, and so these are definitely agents that we would use upfront in a low-risk MDS patient with anemia. There are also agents that stimulate platelet production. These are called thrombopoietin agonists. Eltrombopag is the one that has been studied the most, and it does seem to improve the platelet count safely and effectively in low-risk patients with MDS. It's also been tested in patients who have, in whom Vidasa or a hypomethylating agent, which is the standard therapy for higher-risk patients. When that fails, we may go back and use the eltrombopag if thrombocytopenia or low platelets is the primary issue. However, to date, there's no study that shows that putting eltrombopag with another chemotype agent, like azacitidine, is particularly effective. So we generally don't use it yet as standard of care in that scenario. There's also some warning about using it in chronic myelomonocytic leukemia, as there may be a potential for causing the white count to go up. Another example of what we call supportive care, so these treatments so far are not treating the disease, they're just trying to help us with the blood cell counts. So another is transfusion. So we can transfuse red cells and we can transfuse platelets. We generally can't transfuse white blood cells. Transfusion can be a life-saving, life-prolonging intervention. It's important to realize that platelets only live about a week, and so when we give the patient a unit of platelets, we expect in the best case scenario the count to go up by about 45,000, and it will go up and then wane over the next 7 days. So patients who aren't making any platelets will need platelet transfusion at least once a week. Red blood cells live anywhere from 1 to 4 weeks on average. Generally, 1 unit of blood is going to bump the hemoglobin by 1 point in the best case scenario. The downside of getting red blood cell transfusions are that each bag of blood has about 200 milligrams of iron. And when those red blood cells die off, they leave their iron behind. So ongoing transfusion of red cells can lead to iron overload. We use a laboratory value called the ferritin to monitor how much iron a patient is accumulating over time. But generally speaking, by the time a patient has required about anywhere from 10 to 20 units of red cells, we think it's time to initiate a therapy to try to pull the iron out of the system and prevent further iron excess. Moving into the treatments that I mentioned briefly. So lenalidomide, otherwise known as Revlimid, is a medication that has been given for MDS patients with that 5q deletion. And this is the percentage of patients over time that remained free of transfusion who began transfusion dependent when they started this clinical trial. And it's pretty impressive. Right here is about the 1-year mark. We see that more than 60% of the patients were still transfusion independent at that point. So the median was about 44 weeks, so just short of a year. That means half of the patients were able to remain off of transfusions for longer and half of the patients for shorter periods of time. I have a patient who has been transfusion dependent for several years, more than 5 years now, with this treatment. There is a new drug that has been approved for anemia in patients with low-risk MDS. It's called Luspatercept. This was just approved a couple of months ago, and we're very excited about it, because this group of patients with low-risk MDS in whom we see cells called sideroblasts in their bone marrow have really had very few treatment options up till now. And this drug seems to work particularly well for those patients who may also carry the mutation called SF3B1. Here in the blue boxes, you see the patients who were able to achieve transfusion dependence at various time points, and those patients are compared to patients treated with placebo, since this was a phase 3 trial. So the orange bars represent placebo-treated patients, and the blue bars represent Luspatercept-treated patients. And as you can see, approximately a third of the patients were able to achieve transfusion independence, to come off of the need for blood transfusion in this study. And approximately half of the patients had an improvement in their hemoglobin, even if they didn't meet the strict criteria for transfusion independence. Another area of interest over the years has been using immunosuppressive therapy in patients with low-risk MDS. And the reason for this interest is that there seems to be some overlap with a disease called aplastic anemia. In aplastic anemia, the bone marrow is wiped out by the patient's own T cells. So it's as if those T cells have become confused and start to attack the patient's marrow and stem cells in particular. Those patients with aplastic anemia have an excellent response to a drug that comes from horse serum called anti-thymocyte globulin. What that does is temporarily knocks out the T cells in the patient's own body, and gradually, as their T cells regrow and reset, the hope is that they will stop attacking the marrow stem cells. And this has been effective in 60 to 80% of patients with aplastic anemia. It's been studied in several small studies, but only one randomized controlled trial in which the response rate among patients with low-risk MDS was about 29%. There are some factors in the patient's body which may predict a higher likelihood of responding, such as the HLA-DR15 marker, and also the chromosomal abnormality trisomy 8. Another drug that's been used is called alemtuzumab, but I won't say much about it since it's no longer really available easily on the market. I do want to point out that the group of therapies that is FDA approved for patients with higher risk MDS are called hypomethylating agents. And what that means is that the patients who have MDS, AML, and many other cancers seem to have these little red circles here, methyl groups, on their DNA. And the idea is that the cancer has the ability to put those methyl groups on and silence parts of your genes. What these drugs do then as hypomethylating agents is to pluck these methyl groups off and wake the gene back up so that the gene can work again. The traditional agents, 5-azacitidine and D-cytabine, have been approved for several years, and there is just last week there has been the approval of an oral version of D-cytabine called Inqovi, which I'm sure we will start to see more use of. Now, these drugs are used only in higher risk patients throughout Europe. In the United States, they are sometimes used for lower risk patients, but there are some caveats to that. So, first of all, the MD Anderson did a study where instead of using the full dose HMAs, they used low dose, an abbreviated dose of only 3 days. And they compared MDS patients treated with azacitidine versus D-cytabine. Overall, in terms of the survival at 1 year and progression to leukemia, there was no difference between these two groups. But there did appear to be a slightly better overall response rate for the decitabine-treated patients who had more than 5% blasts. On the other hand, the patients who had fewer than 5% blasts, there seemed to be no difference between decitabine and azacitidine in that group. The median overall survival was not reached in that particular study. I also want to point out a cautionary tale. Originally, the thought was if azacitidine works in higher risk MDS, then we should give it to lower risk MDS patients to keep them from progressing any sooner. But a large phase 3 study conducted with azacitidine in low-risk MDS patients, and it was compared to a placebo, showed there was excess toxicity in the patients who were treated with the drug. So we do want to be careful about rushing to treat patients with low-risk disease who may live many, many years, as that initial graph showed you, with treatments that can have toxicity. However, when patients are transfusion dependent or have dangerously low platelets or white cells that are causing them to get infections, we certainly are eager to find options for them. And one of the things that I'd like to propose is to consider clinical trials if you fall into that category, rather than jumping to standard therapy that might be the best suited for higher risk disease. So this is a list of some of the clinical trial therapies that are out there right now. The first is vitamin C. So we actually have a trial of vitamin C versus placebo for patients with low-risk MDS, but we also include patients with clonal cytopenias in this group category in this trial. So what that means is patients who carry a mutation, like I showed you before with the CHIP, and who also have one low blood cell count. We then call them not just CHIP, but CICUS, clonal cytopenia of undetermined significance. So we're treating patients with vitamin C because it may have the effect of enhancing endogenous demethylation, so sort of doing what the drugs decitabine and azacitidine do, but naturally in the body. And there have been trials of vitamin C over the many years for different cancers, not all of which have been positive. So it's important that we do study these kinds of interventions, although they seem low risk and natural. It's important that we study them in clinical trials. The next drug I wanted to talk about was actually something kind of interesting that came out at the American Society of Hematology meeting several years ago, which was looking at patients who are on antidepressants with SSRIs who had also been treated for MDS, low-risk myelodysplastic syndrome. And as it turned out, there was one SSRI in particular, sertraline, where patients who had been on this SSRI did significantly better. Their survival was actually better than patients with MDS at the same risk level who were not on any SSRI. So this is actually currently being studied in a clinical trial. Another drug under study is called imetelstat. And imetelstat looks like it may improve anemia, again, like Luspatercept, in about a third of patients with MDS who are requiring transfusions and only have low-risk disease. Among those patients who responded, there was a very significant bump in the hemoglobin by as much as 3 grams or more. So very impressive results in about a third of the patients. Unlike Luspatercept, patients did not have to have a specific subtype such as sideroblastic anemia to qualify for this clinical trial, and a larger study is ongoing. There's another study of an anti-inflammatory type agent, and I wanted to explain why that has any interest in myelodysplastic syndrome. So what I mentioned before about CHIP, clonal hematopoiesis of indeterminate potential, those mutations that were found in average normal patients at various age groups, when they looked at the data, it appeared as though the patients who had a mutation had a significantly higher incidence of coronary heart disease and also of myocardial infarction or heart attack than the patients in the same studies who didn't have a mutation. So this was a very perplexing finding, because why would having a bone marrow cellular abnormality or mutation have anything to do with the blood vessels in your heart? And there are a variety of hypotheses about this, but the strongest suggests that the mutation may lead to increased inflammation in the body. So one of the treatment trials that is out there right now for low-risk patients is with a drug called canakinumab. which is an anti-inflammatory agent also used in some autoimmune conditions. So I wanted to put a pitch, if we have a moment, for clinical trials and urge you to consider doing those over taking treatments that are not yet proven. Because clinical trials are really what make the future for us with these rare blood diseases. I hope you've had a chance to enjoy the talk, and I'm open for questions. Thank you.
I see a question coming in from Alan. He's asking what treatments are available for those MDS patients with a 20q deletion.
Hi, Alan. Thank you for the question. 20q deletion, we don't have any specific treatments that are targeted at that particular mutation. That may often be found in lower risk disease. So the clinical trials and the erythropoietin stimulating agents, those would all apply with the 20q deletion.
The next question comes in from Michael. Have there been any notable improvements for patients' blood counts with the off-label use of Luspatercept?
I'm not sure what you mean by off-label. I mean, we now have a label for Luspatercept in low-risk myelodysplastic syndrome patients with sideroblastic anemia. And there's obviously, as I mentioned, good efficacy with raising the hemoglobin and coming off of transfusions. There was also a presentation at ASH this year in December indicating that, to my surprise, there were also improvements in the white count and the platelet counts of some of these patients treated with Luspatercept. And we really didn't consider this an anti-MDS therapy. We considered this a therapy to improve anemia. So that's quite promising and actually somewhat surprising. We'll see if additional data come out to support that.
Thank you, Dr. O'Connell. The next question is from someone who was exposed fairly frequently to benzene, acetone, and formaldehyde in her youth. Her mother was a histology tech in an unventilated area, so they want to know if there's a chance this could have caused their MDS diagnosis.
Well, so it's difficult for me, I'm not a toxicologist, to quantify what your benzene exposure was. It does have to be fairly significant and over a long period of time. But yes, this is a known cause of MDS, one of the few that's clearly been identified in terms of a toxin that has led to bone marrow damage. So it's certainly possible, but you may need to talk to a toxicologist to really understand if the amount of exposure was significant enough.
The next question comes in from Marvin. Have you seen remission without treatment?
That's a good question. No, I have not seen remission without treatment. I have seen some interesting improvements with interventions for other issues that I think may have some overlapping efficacy. For example, I have a couple of patients who have low testosterone levels, males with anemia and bone marrow suggesting myelodysplastic syndrome, that when they are treated with testosterone or an analog of testosterone, such as danazol, that we do get some improvements in their blood cell counts, although those therapies are not considered to be specifically for MDS.
Thank you. The next question is, does swelling in the ankles have anything to do with MDS?
That's a good question. We do see that a lot in our patients, and I don't have a scientific answer for you. Technically, no, that should not be related to MDS. However, sometimes we do see when patients have significantly low red blood cell counts or low hemoglobin and they need a transfusion, they will appear swollen for that reason. May have something to do with the fluid dynamics between their blood vessels and the surrounding tissues. And then the other issue, sometimes patients who are getting a lot of blood, so if they get 2 units of blood at one time and they have a little bit of heart failure, they may not be able to handle that big bolus of fluid and protein that comes with the blood, and that can cause leg swelling. So we certainly see leg swelling in patients with MDS. Some of it may have to do with overlapping comorbidities or diseases that they also have.
Thank you. The next question is, if I'm CCUS, how often should I have a biopsy to determine changes?
Well, that's a good question. We really don't have a standard of care algorithm yet for CCUS. Generally speaking, we follow the peripheral blood cell count, and if a patient is showing a decline in other blood cell counts or a worsening of the original cytopenia, then we would consider repeating the bone marrow at that time, particularly if we were then considering intervening with the therapy.
Thank you. The next question is, what dose vitamin C is recommended? Are there any other natural remedies that can be used?
So vitamin C is not currently recommended for MDS. Again, as I mentioned, there are several clinical trials. We have one, but there are other clinical trials at other centers looking at vitamin C. So the answer is we don't know what the recommended dose would be because we don't yet know that it actually improves MDS. Our particular study is using 1,000 milligrams of vitamin C. Most vitamin C tablets come as 500 milligrams. But again, I really can't say I can recommend this as an intervention until we see what the results of the trial show. There have been interventions on other natural remedies in other cancers, some of which have come back showing they make the cancer worse or increase the risk of progression. So we have to be very careful about using non-approved medications. We are also interested in other herbal or natural remedies that we're still studying in the lab, and we'll hopefully roll out some clinical trials to test those in the coming years.
Thank you. Next question comes from Molly. How do you get involved in a clinical trial? My mother has MDS with ring sideroblasts.
So, well, first of all, the MDS with ring sideroblasts and anemia, Luspatercept is now FDA approved, so she wouldn't need to be in a clinical trial to be given that medication. And you can ask your hematologist oncologist for more information. If your hematologist oncologist isn't up to date on MDS particularly, then you may want to go to a more academic university setting where there's either an MDS Center of Excellence or someone who specializes in MDS that would be more familiar with the latest developments. But if you do want to enroll in a clinical trial, there are several ways to do that. So again, the university or academic setting, they will often have clinical trials available. But there's also a website called clinicaltrials.gov, G-O-V, where all of the clinical trials in the country for any cancer are supposed to be listed. And so you can do a search, and that search can be disease-based. You can then specify which state you're in. You can make other specifications to really find clinical trials that might be relevant for your mom.
Thank you. The next question comes from someone. How does one get into a trial when they live 3 hours away from a research center?
Yeah. So that's a very good question. So one of the things, if the clinical trial is supported by a pharmaceutical corporation, they will sometimes have patient reimbursement programs, which would allow you to stay at a hotel for the days that you need to be there for the trial and may cover transportation costs. There's also, in some cases, there are these new companies that are actually trying to facilitate telemedicine visits for clinical trials. We are not affiliated with one at USC, so I'm not terribly up on that, but they are out there, and you could probably do a Google search for that. But again, I think if you're willing to drive, they will often offer patient reimbursement to help with the costs of travel and staying locally. Some trials are very, very high maintenance, so to speak, where you have to be there quite a bit. But other trials, actually, you may only need to come and see the physician at the site once a month. Sometimes you're even able to get part of the treatment or all of the treatment locally and just the study medication at the site where the trial is. So there are a lot of different possibilities. So before discounting any particular trial because of its distance from you, I would at least go to clinicaltrials.gov, see what's available, and they will usually give you a contact person at the site to call and find out more before you show up for a visit.
Thank you. That was very helpful. The next question comes in from Maria. Is there anything that patients with 5q deletion can eat to raise their hemoglobin and ANC levels?
Yes, thank you. That's a good question. I wish I could say yes. Many, many patients have this question. The anemia and the low white blood cell count of myelodysplastic syndrome is not related to nutritional deficiencies. So unfortunately, there's no specific diet or dietary supplement that we can recommend to raise the counts.
Thank you. Next question. Is there any relationship between MDS low risk and polymyalgia?
Oh, that's a great question. So we have one paper about this. There are a small group of patients who appear to have increased risk of inflammatory or autoimmune disorders, including polymyalgia rheumatica and other even rarer disorders. We don't really understand what the connection is, but there does appear to be a connection there. So this is kind of an area of some controversy and a lack of really good knowledge, but I think it's important to be at a center where there's some interest in the potential overlap between the two. So that your rheumatologist and your hematologist are at least communicating, because treatment for either the MDS aspect or the PMR aspect may affect the other disorder.
Thank you. Next question. How is Luspatercept given, injection or orally?
So Luspatercept is an injection under the skin that's given once every 3 weeks.
The next question is, after the initial IPSSR prognosis on median survival, what calculations can be made after 2 years of diagnosis?
So this is a problem in this disease. We are continuing to use the IPSSR to stratify patients to enroll them for clinical trials, but it is actually not a dynamic prognostic system. So that means that it hasn't been validated for someone who's already received treatment or is 2 or 5 years into their disease. So at this moment, we don't have a dynamic prognostic scoring system, so it's difficult for us to give you a time-based prognosis when you're already a couple of years into the disease. Additionally, those initial prognostic models were not developed based on patients who had received treatments like azacitidine. And so it's also very difficult for us to say for sure how the natural history of the disease is affected by standard therapies and by clinical trial therapies.
Thank you. Next question. I was diagnosed with low-risk MDS back in 2010. I did have serious anemia for a number of years and required regular iron infusion therapy for 5 years. But I've been able to avoid transfusions and iron infusions for 5 years. Having been diagnosed with MDS 10 years ago, I wonder how much longer I will be able to avoid transfusions.
So there may be two processes going on here because MDS, generally we have to rule out iron deficiency to make the diagnosis of MDS if anemia is the only low blood cell count. Red cells are the only low blood cell count. So MDS really doesn't generally respond to iron therapy. So you may have had iron deficiency anemia that has responded to iron therapy. Whether you also have MDS is certainly possible, but the response to iron would not really be part of what we would consider the normal trajectory that's listed on the IPSS prognostic system. If you are off of transfusions and doing well, then that's fantastic. And that means, you're probably on that high flat part of the curve where we don't necessarily expect any major changes in the imminent future for you. Over a long period of time, of course, there may be evolution, but I would want to know for sure that you have a mutation or some other evidence of MDS, because again, the iron deficiency would have been a separate diagnosis.
Thank you. Is there a way to determine MDS risk for someone who consistently has low WBC count, but not yet below the normal range?
Well, so if a bone marrow biopsy has been performed and there is an identifiable mutation, then we are quoting a risk of 1% per year of evolution towards overt MDS. But there are many other reasons for a low white blood cell count. So again, I would want to be absolutely sure that there's a mutation or some other objective evidence that there really is MDS, because other conditions can cause a low white blood cell count.
Next question from Sheila. Is it possible to have MDS and never progress past anemia?
Yes, so it is possible for anemia to be the only manifestation of MDS for the entire course of the disease. I have several patients who are 10 or even approaching 15 years out with just anemia. And so yes, that is definitely possible, especially in that low risk category.
Alyssa has a question on behalf of her father. He'd like to know if you are familiar with shortness of breath. Being on Luspatercept, he's been through 2 cycles and is experiencing severe shortness of breath.
Okay, well, shortness of breath is certainly a manifestation of anemia. So one question I would have would be, was he short of breath prior to starting? And is this just an ongoing manifestation of anemia? The second thing that would be something I'd want to be sure to rule out is in the studies for thalassemia, Luspatercept was associated with an increased risk of some clotting. And shortness of breath can be a manifestation of a type of blood clot in the lung called a pulmonary embolism. The other thing that shortness of breath may represent is something to do with the heart. So congestive heart failure, myocardial infarction, or other conditions associated with the heart. So I would really want to make sure that both the lungs and the heart were tested to better understand this shortness of breath. And then if we're certain that the shortness of breath is just a manifestation of the anemia and he's not responded after 2 doses of Luspatercept, the dose of the Luspatercept can then be increased. And I'm not sure that everyone who didn't participate in the clinical trials would be up to speed on that, but we would increase the dose if the anemia hasn't improved.
Thank you. The next question comes in from Connie. Are there particular foods that affect MDS?
Right now, not to our knowledge, no. I mean, if a patient is profoundly neutropenic, meaning very, very low infection-fighting white blood cells, we will often advise them to avoid foods that are in direct contact with the dirt. So anything with the skin, where you eat the skin, unless it's cooked, because you can get bacteria and fungus from contact with the soil. But beyond that, we're not really able to say that there are foods that make MDS worse or better, unfortunately.
Next question, is there any correlation with von Willebrand's disease and MDS?
No. So there is. This is a really interesting issue, actually. Von Willebrand's disease that you are born with does not lead to myelodysplastic syndrome. However, there is a form of acquired von Willebrand's that can look like MDS because the patients can become very, very anemic. That anemia is usually due to bleeding from the GI tract, and that bleeding can be very profound, very profuse, difficult to find, but the patients would generally be iron deficient. So again, that would give us a clue that if you're iron deficient, this may not be MDS, this may be something else. And acquired von Willebrand, which can be related to aortic stenosis, which is a problem with a heart valve, can be related to having a funny protein in the body that's kind of misbehaving. So there are several things that can cause this acquired von Willebrand's, which leads to very significant GI bleeding and the need for frequent blood transfusions. That is a separate disorder from MDS.
Thank you. Next question. I have low-risk MDS-U diagnosed in 2018. I'm now on my 20th session of IV decitabine, 3 days every 4 weeks. You mentioned the oral decitabine now released. Would I be a candidate?
Absolutely. So the basis for the release of the oral decitabine was simply to show that taking it orally in this new form gave the same blood concentrations as the IV formulation. So I think it would be very reasonable from a convenience standpoint to talk to your hematologist oncologist about whether you could potentially switch to the oral form and just do the same regimen you're doing now with the 3 days. The drug was literally just approved last week, so it's going to take enough 4 to 6 weeks to actually be able to get it, for it to be available through the manufacturing and distribution pipeline.
Thank you, Dr. O'Connell. Next question. If you are low risk, do you typically transition to high risk over time?
So yes, that is a possibility. As you may have seen, or you could go back and look at the 2 graphs I showed. One of them was progression to acute myeloid leukemia. The other one was survival. And the progression to acute myeloid leukemia was a very flat line. I mean, maybe fewer than 10% or 20% of the patients over a 10 to 12 year period will progress. So it's not all patients, but there is a risk for progression to higher risk disease over many, many years, yes. But not all patients are going to do that. Some patients are going to remain low risk and just needing transfusion for many, many years.
Thank you. I have a question from an MDS patient diagnosed in 2011 at the age of 56 with low-risk MDS. Recently, she was identified as having the TP53 gene mutation. A recent biopsy showed 4.2% blasts and an increase from 69% TP53 gene mutation to 79% in 18 months. This past year, she's been very black and blue, and some hematomas and some spontaneous bleeding. She's been offered macrolidumab and Vidasa combination therapy for 2 to 4 months in a phase 2 trial study. as a bridge to bone marrow transplant. And she wants to know if you think this is appropriate for her situation.
Well, I can't make personal treatment recommendations because I don't know her whole case. And I'm not sure exactly which trial that is. There is a drug called APR-246 that is targeting specifically P53 mutation, so that may be the clinical trial they're referring to. Because this is considered an adverse mutation, at her age, I would definitely, in general, someone with this breakdown, I would refer for an allogeneic stem cell transplant. Some people refer patients to go straight away to the transplant. Others refer them first for treatment. I'm on the latter. I tend to treat them first for a little bit to see if I can sort of dampen the disease down. So it sounds like a reasonable treatment course to consider in her situation, but I'm sorry, I can't be very specifically telling you that this is good or bad since I don't know her case.
Thank you, Dr. O'Connell. The next question is, can lower risk patients harboring different mutations like the TP53 or the ASXL1, do they fare worse than predicted by disease risk?
So a little bit, yes. So we don't have a new updated IPSS score that takes into account these finer molecular mutations. The IPSS is taking into account cytogenetics. These molecular mutations are tested using PCR-based techniques, which is different than the routine cytogenetics done on the bone marrow biopsy. So it does appear as though these adverse molecular mutations like ASXL1 and P53 do confer a worse prognosis. And what that would mean is if we think about the patient having, only 20% progression over 12 years or risk of progression, that number would be higher. It doesn't mean the patient is definitely going to develop AML. But it would confer a higher risk. At this time, that would not change our treatment necessarily, but we may be more apt to recommend stem cell transplant in those patients as they show evidence for progression. We also may just follow them more frequently to see if there's disease progression and an indication to start therapy, such as azacitidine or decitabine. So we definitely pay a little closer attention when these mutations are identified, but it doesn't mean with 100% certainty that the patient is going to progress.
Thank you. Next question from Phil. After remission, is treatment still necessary?
Unfortunately, if you're talking about hypomethylating agents, azacitidine and decitabine, yes, we continue to treat for as long as we can hold that remission because it appears as though the epigenetic abnormalities, the methylation, like the cartoon I showed you, go back to abnormal if we stop treatment. And so, yes, we do continue to treat for as long as you're responding. And if there's evidence that you're losing response, we would do a bone marrow biopsy and then decide where to go from there.
Thank you. Next question. You talked about excess toxicity in low-risk MDS patients using azacitidine. What does that mean?
Well, unfortunately, azacitidine and decitabine, although they are not given at doses that are traditionally considered to be chemotherapeutic, meaning just killing cells, or given at lower doses than would be the chemotherapy dose, they do have some chemotherapeutic properties. And unfortunately, most of the time when we start them, the blood cell counts actually get worse before they get better. And so if, for example, a low-risk patient has anemia requiring transfusions, but a platelet count of 70,000, which is pretty safe, it's low, but it doesn't require transfusions and very unlikely to cause bleeding, and then they're started on azacitidine, and suddenly that platelet count goes down to 20,000, they may have a very significant risk of bleeding then. And so we've now added some risk to their overall profile. And so they did see in that particular study with the pill form of azacitidine that they were actually giving some toxicity to these low-risk patients that they didn't already have. So that's what I was referring to there. Now, on the other hand, if you take a high-risk patient whose primary problem is, let's say, just anemia, but in their bone marrow they are teetering on leukemia and have 18% blasts, then their survival and their risk of transforming to acute leukemia is extremely impacted. And then the risk of giving the azacitidine, which even in that case will likely drop their white count and drop their platelet count, the risk is worth the potential benefit of getting them off of that ledge where they were about to become leukemia. So in low-risk patients, that risk may not be worth it, because if they are on transfusions, but they are likely to live for 12 years, then exposing them to a life-threatening bleed from having low platelets may not be worth it.
Thank you, Dr. O'Connell. The next question comes in from someone who developed hemosiderosis due to RBC transfusions. They want to know, what agent do you use, how often, and what's the treatment goal?
So yes, this is a problem with low-risk patients who are chronically transfused. We do try to intervene early. There are a couple of oral agents that we use. One of them, the first that the insurance usually requires because it's been available and has good long-term data, is Xjade. It has a very long name, so I'm sorry, I'm using the brand name. The Xjade is taken orally daily, but has some issues with GI upset. So there is another form of that called Jadanu that might be a little bit easier on the gut. So we usually start with Xjade. If the patient has toxicity or discomfort in the gut, then we move to the Jadanu. Some hematologists will also give an IV version of a iron chelating agent with their transfusions. And there is not a great deal of positive support in the literature for that, but it's something that we've done for many, many years. So sometimes they will add that as well. So in addition to the oral drug, they'll do this IV on the days of the transfusion. And then there's also a subcutaneous version, which you take home and use as a pump with a little needle that you put under your skin. And usually that's given through the night for 12 hours. We've sort of veered away from that because it's not very convenient. It can be uncomfortable. But some patients are willing to do everything possible to keep the iron levels down. I would say that that's something, the degree of aggressiveness is somewhat determined by the likelihood that the patient can go to transplant. If the patient can go to transplant at some time, let's say the patient is still young in their 50s, then I would be very, very aggressive, because the data suggests that patients who go into transplant with excessive iron overload don't do as well as those who have had their iron chelated over the years and kept under control.
Thank you. The next question is, ruxolitinib was listed as a clinical trial but was not discussed. What has been learned about this treatment?
So ruxolitinib is an FDA-approved treatment for myelofibrosis, which is another bone marrow cancer. It also can lead to acute myeloid leukemia. Its primary features are a lot more systemic symptoms, meaning patients lose weight, they have fevers, night sweats, very, very enlarged spleens. So ruxolitinib has a very intense anti-inflammatory effect in these patients. It can shrink their spleen, make the fevers go away. But unfortunately, it tends to worsen their anemia. So that's a real problem in patients who are already very anemic. I believe that I don't have the ruxolitinib trial for MDS at my center, so I'm not very specifically familiar with the trial, but I believe that concept of the anti-inflammatory effect is partially what they're trying to engage with that drug. I don't know any updates yet on what it's looking like it's doing for MDS, and hopefully this December at ASH, maybe we'll get a preliminary abstract on that.
Thank you. Next question. Are there any trials for MDS MLD-RS ring sideroblasts at 15% isolated trisomy 19 with a SRSF2 mutation? Their blood counts are stable, but platelet counts are dropping.
Okay, so the Luspatercept can be used in a situation with 15% sideroblasts or higher if anemia is the primary issue. Again, the Luspatercept is not necessarily meant to be a treatment for MDS, it's meant to be a treatment for anemia. However, as I mentioned, they did include patients that had multilineage dysplasia in the trials, and in a subsequent report that was presented at ASH but not published yet, there were actually some improvements in platelet count and neutrophil count in those patients. So if the disease is still in the low-risk category, Luspatercept, if they're anemic, would be an option. I think azacitidine, if the disease is moving into the intermediate risk category, azacitidine has a very good chance of working. It has been shown to work in patients with refractory sideroblastic anemia and also with multilineage dysplasia. So I don't think that there are some additional studies going on with Luspatercept if you would prefer to take it as part of a clinical trial. And again, if you go to clinicaltrials.gov, you could look that up. MDS and Luspatercept, you would search. But I also think that there are some treatment options. The standard treatment options would still have a high chance of working in this scenario.
Thank you. The next question comes from Robert, who's been a participant in many clinical trials for Procrit, Revlimid, and Vidaza, to name some. He now understands because they all did not help, this prevents him from enrolling in other clinical trials per his hematologist, and he wants to know why.
That's not necessarily the case. I mean, I have a clinical trial for patients in whom Vidaza didn't, or azacitidine didn't work, or was working and then it didn't work anymore. So that's not a contraindication to enter another clinical trial for sure. Now, what the hematologist could be saying is maybe they ultimately decided that this wasn't MDS, or they had somebody review the bone marrow and they felt the disease was actually different than just MDS. And there are several other possibilities, and this does happen sometimes. So I would have to look more specifically at the case to understand why the hematologist-oncologist would be saying that you're not a candidate for other trials. That should not be so.
Thank you, Dr. O'Connell. Next question. Can MDS cause high uric acid?
So elevated uric acid can occur when blood cells are rapidly growing and dying. So the MDS-MPN overlap syndrome, where the white count is elevated, or MPNs, the myeloproliferatives, where one or more blood cell counts is elevated, those can lead to an elevated uric acid. The other time that we may see that rise is if the bone marrow has a lot of blasts and we initiate a therapy like azacitidine or decitabine, we may see a rise in the uric acid as we kill off those bad cells.
Thank you. Next question. Where can I get more general information on treatment with Luspatercept, on the dosing, complications, things of that nature?
So if you do a Google search for Luspatercept patient information, you can find it there. You can also go to the Luspatercept FDA prescribing information, and the website, the company's website will emerge, and you can select that you're a patient, and it will give you information there. The MDS Foundation may have some information on their website. So I would stick to very established websites to get this information, either MDS Foundation, Leukemia Lymphoma Society, the prescribing information page that the company hosts, where you can go in as a patient and get more detailed info.
I think we have time for one more question, Dr. O'Connell. What medications outside of prednisone have you seen work for low-risk MDS patients who have sweet syndrome with low-risk MDS?
That's a good question. We have generally used prednisone in that situation, you're right. If the sweet syndrome is very difficult to control, that would be one of the few times that I might move forward to a hypomethylating agent for a patient with MDS. I would definitely want to make sure I have a very good recent bone marrow biopsy and a myeloid molecular panel in case there are any targetable mutations. There are a couple of other drugs out there now targeting some of the mutations like the IDH2 mutation. So this would be a case I'd really want to see how bad off is the patient, how bad is the sweets, are there any other low blood cell counts, because I might consider moving to therapy if the patient's really suffering. And we really don't want to keep a patient on a very long-term course of high-dose prednisone because of the immunosuppressive effects and other adverse effects of steroids.
Thank you all. That's all the time that we have for questions. Thank you, Dr. O'Connell, for your wonderful presentation and your time. For those of you who still have questions, please feel free to reach out to me at ahassan@mds-foundation.org. If you missed out or would like to revisit this webinar, be on the lookout for an email that will provide you with the link within 4 to 7 business days. On behalf of the MDS Foundation, thank you for joining us. This concludes today's program.
Thank you.
Thank you. That's all the time that we have for questions. For those of you who still have questions, please feel free to reach out to me at ahassan@mds-foundation.org. If you missed out or would like to revisit this webinar, be on the lookout for an email that will provide you with the link within 4 to 7 business days. On behalf of the MDS Foundation, thank you for joining us. This concludes today's program.